Hello, my name is Jim Cosby. I am a social worker. I have been a social worker for over 40 years, most of which has been in Colorado, and have seen a considerable evolution of mental health changes, services, resources, and the like. The novelist Barbara Kingsolver said recently that in a world as wrong as this one, all we can do is make things as right as we can. That's what I'm here today to talk about. I want to say right off the bat that we made a mistake. We were wrong. We may have made the best choice based on the information that we had at the time, but the information was insufficient and in many cases inaccurate. In 1963, the Congress of the U.S. passed sweeping legislation designed to deinstitutionalize the mentally ill. Patients would be remotivated, returned to their community and their family where they could be loved and cared for and restored to functioning roles while receiving treatment in the newly formed community mental health centers. New medication had been discovered that significantly reduced the overt symptoms of psychosis and would presumably allow them to live a normal life. Besides, it was not really humane to warehouse all these people in mental health institutions in states across the country. The technical term for this is unintended consequences. It was a triumph of hope over reality. Recent research tells us that 15% of males and nearly 33% of females in jail settings have a serious mental illness. Rates of serious mental illness in state prison populations are at least 2 to 4 times higher than that in the general population. Existing interventions have done very little to reduce these numbers. How do we categorize progress? According to a position paper from the Equitas Project in 2018, there are 4 broad areas. Keep people with mental illness out of the criminal justice system altogether by treating them before they commit crimes or have a crisis. If someone who is clearly mentally ill commits petty theft or another misdemeanor, get the offender help rather than sending him or her to jail. For those who are jailed, get them treatment behind bars, and just as importantly, after they are released. And fourth, if someone with mental illness dies in jail, hold both the system and the staff members accountable for mistakes and maltreatment to spur improvements and prevent future tragedy. I would add 4 other areas to that list. Expand service options. Learn from and utilize the evidence-based research data. Ensure adequate resources. And lean on the housing first concept that has been prioritized in Denver recently for addressing homelessness. If we're to provide adequate and effective treatment interventions, there needs to be safe places where that treatment can occur. What parole officers have discovered in the probably last 10 years is that if you put somebody on parole and they have no place to go when they get out of prison and then they have nowhere to live, homeless people don't carry daytimers. They barely know how to operate a cell phone. They've been incarcerated for very long. They certainly don't make it to appointments. They don't follow through with the expectations that their prison supervisors gave them, handed them a piece of paper when they left and said, here, check in with so-and-so at this address. It's not realistic. It's not the kind of solution that is practical. Since the advent of managed care in the 1980s, the focus of mental health treatment has been on brief therapy or solution-focused therapy, or even in some cases, single-session therapy. Insurance companies made it very clear that they did not want to fund long-term therapy. They wanted to see results quickly. For many people, this was fine. When offering crisis intervention, a brief therapy approach can often work well too. because the research indicates that most crises resolve one way or another within 6 weeks. Providers were incentivized to provide less and less therapy with systems of capitation rates and having providers participate directly in the cost savings. State hospital beds were allocated to mental health centers. In Colorado, even the Medicaid reimbursement to community mental health centers was capitated, resulting in mental health centers cutting back on the amount of direct services in order to pocket a larger portion of the Medicaid payments. Long-term care was redirected to nursing homes, which have become the new warehouses for persons with severe and persistent mental illness. Now, recent data indicate that 30 to 40% of the homeless population suffer from severe mental illness. Colorado has recently been touting their new 1-800 number crisis line and area walk-in centers. This is a start, but if there is no place where people can stay for respite or crisis intervention, it makes the job of the telephone responders considerably more challenging. Police departments have been training officers in the skills of crisis intervention, CIT training, but the original idea of that from Memphis included having a place where police could bring individuals in crisis and drop them off. Such 24-hour facilities have not materialized. 40 years ago, those facilities were hospitals, including state hospitals. Now, psychiatric inpatient facilities focus on getting medication started and the patient released in 72 hours. There are several problems with this approach as regards the severely mentally ill. It can often take longer than 3 days to get symptoms under control and medications restabilized. If the patient is released too quickly, they are less likely to remain medication adherent. If they start and stop their meds repeatedly and suffer a psychotic relapse at each interval, they do not return to their previous level of functioning. So each time they go through this cycle, they become less and less functional compared to where they started. So by maintaining this start and stop form of treatment, the system is essentially making the patients worse over time. There are very few remaining long-term treatment settings for severely mentally ill people in Colorado. In other words, there is no safety net for those in our community and our state who suffer from severe and persistent mental illness. It can take years for such individuals just to come to the point of acknowledging that they have an illness that is going to require treatment and management. Then it can take even more years to learn the management skills necessary to function in spite of their disease. Where does one go for that care? As of today, that place is the criminal justice system. Of the 17,785 individuals who are currently incarcerated in the Colorado prison system, 7,200, or 36%, are identified with mental health needs. About half of those will be paroled or returned to the community each year. In Colorado, there are 1,112 psychiatric beds available in the general community. And nearly 10,000 mentally ill individuals in criminal justice facilities on a daily basis. I can speak from personal experience that jails and prisons are very poor environments for providing mental health treatment. They are intimidating, they're cold, they're threatening, and by design, they're structured to impress the inmate with feelings of powerlessness. What do I think needs to happen? State hospitals need to be reinstated, restructured, and refunded so that we can provide a safe, structured setting where patients can be a member of a community and get a sense of belonging. They can get the rote message about being ill and reinforce the importance of managing that illness, taking their medications. They can learn to stay on their meds and work collaboratively with the doctor. They can learn specific skills, such as reality testing, social skills, vocational skills. Many years ago down in Pueblo, the patients, when there were 6,000 of them all in one place, they used to milk the cows and gather the eggs and shear the sheep and work in the laundry. ACLU said, well, if you're going to do that, you have to pay them minimum wage, of course. Well, I don't think they considered that they were also getting room and board and clothes and daily care. I mean, there's some trade-offs that I think are realistic to look at, but I think the fact that they were in a safe place and not just returned to the community where they were not particularly wanted or cared for is a far better solution than what we have going now. The forensic program that I'm familiar with, where NGRI patients have been sentenced to the state hospital in Pueblo, has historically had a very reasonable treatment plan where over the years they teach people how to prepare to return to the community. And it often takes many, many years. They have to justify to the judges that the person is going to be safe when they return. So they may have a few additional steps that they have to take that may not be necessary for everyone. But the fact of the matter is that there is a process of learning that can occur where people do return to the community and they are prepared to receive services in a less structured setting. But as we currently face the situation, people are released to the community and they're not prepared to deal with the circumstances. They don't have the skills that they need, and they don't have anywhere to live. The families that in 1963 we claimed were waiting to welcome them home simply aren't equipped to manage their medications and take care of them and deal with the conflicts around, I don't have to listen to you, I'm an adult now, and all of those issues that arise when an adult returns home makes it very difficult. We need to have other options, and we can't expect families to do that. The number of homeless people that I see on a daily basis, their families no longer have much to do with them, period. They have become not only homeless, but familyless. And that's not a solution. I think that the state hospitals and the state of Colorado has been remiss in offering that as a safety net. That I hate to...
Mr. Cosby, we're well past time.
Oh, I was afraid that was going to happen.
We know that happens. That happens to everybody. So if you could just wrap up.
I will.
We'll give you some extra time.
I will end with a quote from a former director at Fort Logan who said that we don't need these units anymore because there are plenty of resources in the community, as they were shutting down the geriatrics units, the adolescent units, and the children's units at Fort Logan. I think that's appalling. I think it's appalling that he had that point of view. I think it's appalling that a director of a state hospital has no concept of what a safety net agency is there to do. And I think we need to be aware of that as we look at who do we hire and how do we operate on behalf of those people who cannot advocate for themselves. Thank you for the opportunity.